It's a pleasure to be here, looking for this button. You all really are the heroes. The Carolina breast cancer study is really unique, and to appreciate it, probably 20, 30 years ago when these ideas were formed to start this, very little was known about following people long-term, especially African American people. And there were great disparities in care that persist. We're going to talk about them. But this study has really provided leads and research to fill a lot of these gaps, and is so important. We've learned so much. So thank you all for participating, and thank the families who supported you. So we're going to talk a little bit about the state of the science. We're going to cover risk factors. Can we prevent breast cancer? We really can't prevent it, but we can lower your chances of getting it. We'll talk a little bit about disparities, and then some of the exciting things happening with healthcare. So breast cancer is the #1 cancer type in women. And as we've heard, it's about 250 to 300,000 new patients each year. New patients each year. That number is kind of stable. It's the #2 cause of cancer death. So that's a major problem. 40,000 patients a year. Anybody know #1? Lung cancer. So if you're smoking, you're going to cut that out at the end of this meeting, right? You're going to stop that. And in North Carolina, we have almost 8,000 new patients, and we have close to 1,400 people die every year of breast cancer. So this is a major problem in our state. And we have lots of survivors, and probably there's millions of breast cancer survivors in this country. We're really not sure. But because you're a survivor doesn't mean you haven't had problems related to your breast cancer treatment and don't need other support along the way. So this is a major illness. So what can we change? Well, we're born with all these genes. We can't really change them very much. Although I'm saying that, maybe we can change them someday. We're getting better. And we can't really change our age. So one of the major risk factors for breast cancer in this country is age. And if you look at cancer in the United States and you watch TV, the people you see are young people, right? They're Stand Up to Cancer, they're Brian's song, right? So the average age of cancer in this country is 67. 67. So as we age, our risk of breast cancer goes up dramatically. And I'll show you some of that data. We can all do things to help our general health. And it sounds so trivial. So we had a great exercise demonstration here. It's important. That 150 minutes a week, which sounds so easy, is rarely done by most people. And it actually saves lives. It builds your muscle mass, you're healthier, you function longer. And certainly just maintaining a healthy diet. There are no fad diets. You know, today every one of my patients is saying, I stopped eating sugar. You know, but when we do their blood test, if their blood sugar was 0, they wouldn't be on the planet. So your body is making sugar, and you need sugar. You need to eat judiciously. You got to watch those calories, you know. It's not that people eat a Big Mac every day and gain 10 pounds a week. It's that every month on that scale, you're up a half a pound. And by the end of 5 years, you're up 10, 20, 30 pounds. Very slow. So we can all work on that. There are drugs for women who are at very high risk, pills that people take. Frequently they're used to treat breast cancer, drugs like tamoxifen and others. But most women really object to taking this for the side effects. And unfortunately, even in huge studies, it's hard to know how many lives they save. They lower your chances of getting breast cancer, but those breast cancers are usually curable anyway. So these drugs are really not for everybody, but certainly are helpful to selected patients. Now, what are the disparities in breast cancer? And disparities, we mean differences in outcomes among different groups. And so, are there disparities in who gets breast cancer? And what about people once they've gotten it? What about their outcomes? And do we know anything about them? So, this is looking at cancer by a race in the United States. And NHW, non-Hispanic white. So you can see that right now, most breast cancer, the highest numbers are in whites, but they're trivially different now from African Americans. NHB, non-Hispanic black, is what that means. So you can see they're about the same here, and I'm not going to press this, it may go the wrong way, but you can see those numbers. But if you look at the dark blue at the bottom, those are the mortality rates. That's the number of people per 100,000 who don't survive breast cancer, and it's much, much higher for African American people than white people. Now, if you go down the list to Hispanics, other groups, they seem to have less breast cancer. But I don't know how accurate those data are, because you really can't track a lot of these people on the census these days. They don't want to tell you about their breast cancer or any other problems. So those numbers may be incorrect. But nevertheless, it may be a little bit different for them as far as risk. This complicated slide is showing you breast cancer by age and by race. And you can see, no matter what group you fit into, breast cancer rises dramatically as you get older. Now that curve kind of peaks at the top. You can see 75 to 79 and drops a little bit. And that may be not because breast cancer incidence is less, but because we don't have accurate data. Because once people get in their 80s, we're not always sure what kind of health care they're getting in the United States, and it's not as easy to track. Or maybe people who live that long have unique genes, which we don't know about, which lower their risk of breast cancer if they get into the 80s and 90s. So that may be good. And if you look at the mortality, it also follows. No matter what group you're in, as you get older, your chances of dying of breast cancer increases with age. So why are there differences in groups? Well, one is biology, right? When we talk of biology, we're talking about the genes in the breast cancer, and we'll show you breast cancer is at least 4 or 5 different diseases, just like pneumonia can be tuberculosis or staph or the flu. Breast cancer is multiple diseases. Is it screening? Is it one group isn't getting checked as much as another with mammograms and other tools for early detection? Is it access to care? In other words, you've got a problem, but you can't get to see a doctor, or you don't have the funds to afford seeing a doctor or get into the right place. Is it adherence to treatment? You've got your breast cancer. We put you on medication. Are you taking it? And then for a lot of people, it's not their breast cancer that ultimately is their life-threatening problem. It's their other diseases that they have as well as their breast cancer. High blood pressure, heart disease, obesity, other problems. So when we look, what are the reasons for the disparities? And we've got to consider all these issues. Well, one thing, the genetics today is incredible. So this little, I'm going to figure this thing out. Oh, maybe not. I'm not a surgeon, so you don't have to worry about any of this. So this is a little plastic case that you can put a drop of cancer in, a drop of blood in. And in this square are embedded thousands of little pieces of DNA, thousands of genes. And so what happens is you get your blood in there, and we break down your genes and then put it on this square and see if it sticks to it. And we can tell whether you have too much of a gene or too little of a gene, and that may be related to breast cancer. So we can look at thousands of genes and see if there are differences among people. And this is just incredible technology. And this has led to all the new things you're hearing in personalized medicine and special treatments for tumors. This is truly amazing technology. And this is what it looks like. So this is a group. Each vertical line here is one patient, and across here are all the different genes. And what we can do is arrange these genes. A computer does it. And what it does is it's taught us that breast cancer is about 5 types. And they range from people who have what we call hormone receptor positive breast cancers to people who have what we call triple negative breast cancers. And I know some of you have had that. And those are people where both their female hormones and this gene called HER2, those genes are really absent. They have absent function in the breast cancer cells. So those are a different type of breast cancer than the majority of women today whose breast cancers are sensitive to lowering female hormones. So this is an amazing thing. When you think of it, each one of these is a patient and looking at all these genes, and then this is in the breast cancer, trying to figure out what's different. And so we have the types of breast cancer kind of defined, and then we've looked in this study between whites and African Americans. And what's the difference? So first of all, these luminal A and B, these are the hormone receptor positive breast cancer. So those breast cancers are the most common, and they're less common in African Americans who have more of these basal-like, which are triple negative breast cancer. And that's very important because these triple negative breast cancers tend to grow more quickly, and these are the people who tend to recur in the first 5 years after treatment. It's interesting that the people who have hormone receptor positive breast cancers over here, their cancers grow more slowly, but they're the people who tend to have relapses at 5 years, 10 years, 15 years, even out at 20 years, the horror stories you hear about. So by the time you follow a group of patients like this study has for 25 years, even though there's earlier recurrences for the triple negative breast cancer, by 25 years, when all the people with the more favorable types have slowly relapsed, by 25 years the outcome's the same as far as surviving breast cancer. So this study has taught us much. When we look at that more graphically, we can see this, and we can see that even though for the more favorable cancers, that African American patients on this curve, these are survival curves. So if you look here and you look equivalently here, you see that one group isn't doing as well as another. But we've learned that even for the more favorable cancers, African Americans seem to be doing worse. And we've learned that may be an adherence problem, maybe not taking your pills or other medicines. When we give people chemo, we know they're adherent. They're in the chair getting their IV drugs, right? But when we send you home to take your tamoxifen or your aromatase inhibitor, we don't know what you're doing. You know, maybe you're not taking it, maybe you took it for a while, maybe you stopped it, etc. So those are the issues and disparities, and we're still doing a lot. There's a lot of work at UNC going on to solve these problems by actually getting the people early and making sure they're taking their medications, try to teach them more about the side effects and the importance of medications. So those are the issues and disparities, and we're still doing a lot. There's a lot of work at UNC going on to solve these problems by actually getting the people early and making sure they're taking their medications, try to teach them more about the side effects and the importance of medications. So what about some of the exciting research? And what about prevention? Well, we've talked a little about healthy diet and exercise. I'm not going to dwell on it, but you don't need bad friends. You guys got this right. You don't want to go on a great dinner with someone who says the weather's lousy, I can't park. You want to pick good friends in life no matter what you have. So that's very, very important. What about preventive therapy? So adjuvant therapy is something many of you in the room have had. So adjuvant therapy, you had your cancer, they removed it, you got treated, and to your knowledge and your doctor's knowledge, there's no cancer cells left in your body. But you can't be sure, because one drop of cancer has 1 million cells and can go all over. So if you've had a normal CAT scan or bone scan and it's negative, it doesn't mean you don't have cancer. It means you have none or just a little. Just a little. There's no test for any of us in the room that can tell us we don't have cancer right now. So what we do is, based on your risk and your type of cancer, we give you either chemotherapy or estrogen-lowering therapy, sometimes called hormonal therapy, not a great name. And the purpose of that is to, if you have cancer cells that are hiding somewhere in your body that can't be found by any tests, we can kill those cells very early on. Once a cancer shows up in someone's bone, liver, or lung, we can treat it and do well. But cure is highly unlikely. So the best thing is to get it early. So this is adjuvant therapy. And these are data on drugs like tamoxifen, and I suspect some people in this room have taken this drug. And these kind of curves kind of show you that here's tamoxifen patients, and here's patients either on a placebo who didn't take it, and there's a 14% improvement in the breast cancer coming back by taking the drug. This goes out, though, to 15 years, and you notice this curve is sloping down, so that means that each year people are getting relapses on these drugs. So one of the breakthroughs, I think, in the last several years is how long to take these drugs. Should you take them 5 years, 10 years? Most people I know of have side effects and want to get off these things. So how long? And there are now tests available that can help us. So this is just an example of a test where we could pick people where there was a 30% risk of the cancer coming back after 5 years compared to a few percent. So these people, we can say, you know, if you're having side effects, there's going to be little value for taking these pills any longer. So that's now available to us. And then there are other things like using tumor genetics. This was a trial that was just in the Wall Street Journal and New England Journal. What's the value of chemotherapy in younger women with favorable breast cancers, clear lymph nodes, who are going to take drugs like tamoxifen and things 5 years? Is chemotherapy really going to help that patient? So instead of trying to use an educated guess, what we did was a study where women had to agree to be a coin flip, chemo or not, and they all got drugs like tamoxifen for 5 years. And what it showed is, there's actually two curves here. If you had a patient with a low genetic score on one of these tests, there was absolutely no value to chemotherapy in those patients. So we're able to sort out who might need things like chemotherapy from who might not in selected patients. And that's been a major advance in cancer care. Now, to finish off a few things of the future, we're doing work at UNC. Why do you treat a patient with a drug? You have two patients in the room. They have similar types of cancer. Why does one do well and the other not? You know, everything looks similar. Well, it may be they have different genes that break down the drugs differently and they don't work the same way. So in this study, we're looking at little engines inside the cancer cells that metabolize drugs to try to figure out what works best. Really very, very cool. In ending this, there are lots of exciting things. We've talked about risk factors. You can't change your genes, but you can change your lifestyle. And by the way, it's not just breast cancer. So things like being overweight are related to colon cancer, heart disease. Most women now with a diagnosis of breast cancer are going to survive it, even though we saw that sadness of the 500 people in this study. Most are going to survive it. So what's going to happen? They're not going to be immortal, right? They're going to die of something. And what is it going to be? It's going to be heart disease. It's going to be the unfortunate problem of getting another cancer, a non-breast cancer. It's going to be strokes and other things. So by changing your lifestyle, you not only help your breast cancer, but you improve your chances of getting really into old age and being much healthier. So I'd like to thank everybody here for participating in this study. This has been a great study. If you go on the website, you should look at all the great publications that have come out of this study and that will continue to come. And you're really the heroes and champions, and it's a privilege for me to be here with you today. Thank you.